Disposition. So what do we mean when we say patient disposition? We'll jump straight in. What do I mean? What does anyone mean when you say patient disposition? Pardon? Okay. So, yeah, that's one way. Yep. Exactly. Disposition comes from dispose. That's where the word comes from. And that means, yeah, what are you going to do with them once you're finished? Literally, what are you going to do with your patient once you're finished? So there is that disposition, which is what is the patient's disposition when you walk in. And then in paramedic transport terms or treatment outcomes and pathways, the disposition refers to something slightly different, but that is also a correct term. Yeah. So how are you going to dispose of this? We used to, as ambulance officers, you call, we haul. That's what we're doing. Yeah. We've kind of changed that in the last 10 to 15 years to slowly start introducing different pathways for our patients. Very slowly. So it's taken a lot to change people's mindsets. Okay, because people are scared that they'll get in trouble if they don't take patients to hospital. But I guess what can happen if you take a patient to hospital? Talk to me about what can happen to patients if you take them to hospital and they don't need to go to hospital. Long waiting times. What would that do to a patient? Yeah. Yep, totally change their whole perception of the healthcare system. Yep. Infection, what do you mean? Beautiful. Did I put that up there? I did. Yeah. Cool. So what does that mean to you?
It puts them at risk. So if you've got someone like an elderly person that you deem doesn't really need to be seen by someone straight away that can go to their GP, they're probably immunosuppressed or immunocompromised already, so leaving them at home would be a better option because they're at less risk of infection. Like you've got your big super bugs that
Yep. So you're introducing potentially your patient to danger by taking them to hospital, even though it seems like the easiest option?
Like infection control, like the patient coming in to see gastroenteritis, you don't really want to
Yep. Yep. So you're putting your patient at risk, but you're also putting other patients at risk? Yeah, I don't know about you, when you get gastroenteritis, has everyone had gastro at some point in time? Yep, there's a few nods. The ones that are shaking their heads, well done. Wait till you have children. Anyway, they bring everything home. But there's no way in hell you would catch me in any emergency department in the state sitting on a public toilet with vomiting and diarrhea. You couldn't make me do that. I'd have to be heavily sedated to be forced to do that because I couldn't think of anything worse, really. Sharing a bowl that all the other people are sharing. Anyone that's had gastro knows you probably get really well acquainted with a bowl. Then you've got people knocking on the door. Can I come in? Excuse me, sir, you need to hop out now. Someone needs... And you're like, you're vomiting up your guts. Yeah, so there is that as well. And you don't really want to go with gastro, but you might need to. So then what are you going to do? So that's a thought process too. Yep, good one. What else? Waste of hospital resources. Yep. And why? What do you mean by that?
Well, I've noticed these ones bed block.
Yep.
If you're using beds unnecessarily, you don't have anywhere to actually
Sick patients. Yeah. And a lot of the time, if you think back to your placements, you probably went to some low acuity jobs and you're like, ugh. Or the paramedics were like, ugh. Why are we doing this for? And you take them to hospital and you're like, you're part of the problem. You're bringing a patient here that doesn't need to be here and you're too lazy to not think about other options for this patient that are best suited. Like, have you exhausted all other options if you think your patient doesn't need to go to hospital? Because if not, you're part of the problem that's contributing to them going to hospital. Yeah? Who experienced that on road? You went to a low acuity case and they just popped them in the car and just drove them to hospital and you were like, and then they treated the patient like crap or were just dismissive of the patient, like you're wasting our time, like how dare you? we're paid to be here to help you, but how dare you waste our time? Yeah. So, you know, those patients may not know any better. They may not have a high health literacy, and then you're just treating them like crap. It's pretty appalling, I think, anyway. And it's not really being a patient advocate, which is what our healthcare job is about, doing the best for the patient. Yep. So talked about delirium. What do you know about delirium?
It feels real for the person that's like when it's occurring for that person. So it's hard. Like you can't exactly dismiss what's going on. Like, but you don't have to agree with them and say, "Oh yeah, I can see that man on the ceiling." But it's hard. You've got to be very patient as well. And it can happen in elderly people if they have a UTI or an infection. Hypercalcemia can cause it, which I've just learned. Or just them being out of their own home and in a hospital, it brings on stress, and it can literally within a day just send them from 0 to delirious. It's actually scary how quickly I think it can come on.
70 to 80% of people that have cognitive decline of some sort that are in a nursing home, if they go to hospital, they will develop a delirium and be in hospital for an additional 2 to 3 weeks, in which time they will pick up community or hospital-acquired infections. And then they'll be pumped full of a whole lot of other drugs to try and reverse it. Psychotropic drugs sometimes as well, which have their own side effects, which then throws all out their other health out. So taking an elderly patient that's got cognitive decline to hospital, you can guarantee, almost I'd place bets on whether or not they would get an infection. I would back that horse. Yeah? So just being mindful of that, just because, you know, the nursing home staff say you have to take the patient to hospital, you don't have to take them to hospital. You don't have to berate the nursing staff. You can equally educate each other on what's best for that patient at that given point in time. Okay, so being mindful of that delirium, it's huge, and there's so much research out there that's been out there for half a decade or more. Yet people and paramedics continue to bring these people in. There's bright lights, they're out of their normal environment, and that causes a delirium for them. Yeah, so if you can keep that patient at home or in that nursing home, that's the best option for them. And that's what literature shows. That's not just a personal opinion. It's heavily backed by the literature. So keeping that in mind. So what dispositions do we have as paramedics? Throw some at me. Transport. What does that involve, Georgia? Yep. Cool. So from point A to point B. Cool. What other transport dispositions do we have? P5? What's P5? Beautiful. So non-transport with referral, healthcare referral. Yep. Yep. So non-transport with patient advice. Patient left with advice. Yep. What other dispositions do we have? Yes and no. We're still taking them to hospital, so we're still going from A to B with that, in that regard. So I like where your thinking's heading. Refusal of transport. Yeah, so non-transport patient refuses. Yep. What else? What do you mean by that? Yep. Yep. So in Victoria, I think it is, paramedics, and I think Queensland do the same, paramedics can call up the non-emergency transport and say, this patient needs to go to hospital, it's non-emergency, can I book them in within the next 3 hours? Non-emergency transport will come and pick them up to take them to hospital. Yeah, or take them somewhere else they need to go, which is amazing. It's fantastic. London Ambulance Service do something similar as well, where you can organise someone to take them to a low acuity clinic and not to the hospital. So it's pretty cool. Get that.
You can also drop someone home as well.
You could what, sorry?
Drop someone home.
Beautiful. So would that be a transport or non-transport? Transport, non-transport.
Like you're transporting them, but you're not transporting them easy, so
So would it be a non-transport patient self-care? Maybe with referral, or could, if you drop them at another healthcare facility? So you can do that. I've done that. And just said it on the radio. Just dropping patient at GP. I said, why? And I said, well, it's what the patient needs. And they have no other way to get there. But then you've got to think, if they've got no other way to get there, how are they going to get home? So you organise someone to come and get them home, whether that be community transport, or you talk to the doctor directly about organising a taxi fare, or you help them book a taxi fare with their pensioner card, or something like that. You know, that's what we can do. And yes, it's a tiny little bit of extra effort, but that patient goes to their doctor, you've dropped them at the doctor's service, you've handed over care, you can actually give a face-to-face handover if you like, and you've organised care afterwards. So sometimes we don't think that far in advance if we're not going to transport it. Just be like, oh, we just picked you up, you're fine, you don't want transport, no, okay, sign here, and we leave. But we haven't thought about why that person fell. We'll talk more about this next week. Why that person fell, or how that person's going to attend any of their ADLs once we're gone. So it's always important to think of, if you're organising something, why you're organising something, and what the other end of that healthcare spectrum looks like for that patient. So if you're saying go to your doctor tomorrow and they're very sick, what are you going to do? What are they going to do overnight if they can't get into their doctor? You know, what concerns might they have at night? Can you change those concerns or do anything to alleviate them? Or are you just going to walk out the door and say, my shift's over, the night shift can deal with this patient when they call back, because you know they will call back. Yeah? So realising that if you just leave a patient at home, it doesn't always mean that it's what's best for the patient or that the patient's going to be fine. Oh, what did I do there? Oh, there we go. So we've got transport via ED, transport non-ambulance. So you can recommend to someone for them to go up to hospital in their own transportation. You know, I've had someone say, I'm going to hospital, and I've said, no, you're not. In a nice way, I'll cut that short. But, you know, I've never had anyone just, they said, I really want to go, and I've explained the reasons why, and that it's inappropriate to get another emergency ambulance to this address based on my knowledge and understanding of what was going on. But I recommend you go to your doctor. But if you wish to go to the emergency department for this presentation, I can give you a copy of your documentation. You can take that up to hospital, but know that my documentation will say that I advised you not to go to hospital, because that's what it will say. Yeah? So, but there might be times when you suggest they go to hospital, but you know that an ambulance isn't the most appropriate, and there's a lot of jobs going down, and that this patient's going to have to wait another, 9 or 10 hours sometimes to get another ambulance crew there. Then what can you do if it's safe for that patient to go up in alternative transport? Is it a child? Can the child go in a car seat? Is the family confident and comfortable with that? Are there other options? But you have to be 100% sure that patient is safe to do that. So that's where your decision making comes down to it. And a lot of people are scared to back themselves. But if you know and you've done a thorough and extensive assessment on this person and their needs and given appropriate treatment, then there is no reason that when you make that decision you won't be backed. Yeah. ED by non-ambulance transport. You can have non-transport deceased. I guess we didn't really cover that. That's a given. You might even have transport deceased. That can happen too. In some country towns, you transfer deceased to hospital and things like that. Non-transport, patient refuses advice. So you could say, no matter what you do, nah, come on. You've had cardiac chest pain. Yes, it's been resolved by some GTN. I'm not happy with your ECG. It's not showing you've got a STEMI, not That's not telling me anything really. It's just telling me you're not having a STEMI, but for all we know, you could be having a non-STEMI. But I can't tell you that. So, but they could just tell you to F off. And like I said in last week's online lecture, if they've got competency capacity and they tell you to do that, that's fine. If they tell you to do that without you knowing, then that's a different story because they haven't demonstrated anything to you about the competency capacity. Okay? But people have a decision if they're in sound mind to make stupid decisions about their own health, and there's nothing that we can do about it sometimes. Yep. Referral to community-based non-ED options and transport third door. So that's pretty much, so first door is planned admissions to hospital for healthcare. That's what's called first door. Second door is going via ambulance to hospital. And third door within healthcare avenues means referral out to other services. So if you ever hear those topics, we talked about Victoria, Queensland Ambulance Service. There's a minor injury clinic in London, for example, where you can say, go directly here. So there are some low acuity areas that you'll know. There's, I think next to Liverpool ED, there's like an outpatient setting where people, a big GP kind of super clinic where people can go. So a lot of people that wait in the ED too long just walk next door and go in there and get seen by a doctor quicker. So, but people don't know that exists. So if they don't know it exists, how can they access it? So that's part of our role for patient education as well. And really, I've never, apart from one or two occasions, never been able to not get a patient where they need to go based on their own decision making. So if you talk to a patient and give them enough understanding and lead them in that direction without coercion, then they can make that decision by their own self. It's like when you go to a back pain and you're talking to them and they said, I haven't been able to move, I haven't been able to do this. You're like, okay, so what have you been able to do? Have you been going to the toilet, for example? Yeah, I have, but it's so hard to get up. And you're like, oh, good, but you can get up. That's a great thing. You don't say, oh, well, you can get up now. You don't say that. You use that as a positive point. Well, we can get you to that point because you can get there, and that's great. We're going to give you some pain relief, and we're going to give you some exercises, and we're going to slowly start to get you to that point where you can do that. Okay, you won't be pain-free, so don't lie to them, but you can give them the steps along their journey of how this condition's going to go and what's best for them, so that when you offer that clinical decision of transport or non-transport, they've come along that whole line and that whole road with you, so that when that suggestion pops up, they're already with you and are going to agree with what you're saying because you've included them the whole time, not just turn around and said, I'm not transporting you. Yeah? So being mindful to keep the patient involved along the whole way. We always talk about talking with your partner, talk with your patient as much as you can. Okay. So just amongst yourselves, just read this case study. Probably give you 2 or 3 minutes and just think about what the appropriate disposition is for the patient. You've got to have a rationale behind it, okay? And what are the outcomes of your risk assessment? So any patient you visit, there's a risk there. Any patient you choose to transport or don't choose to transport, there's a risk. And if you have these risks and you want to leave them at home, how are you going to mitigate those? How are you going to mitigate doesn't mean completely eradicate. It means how are you going to minimise that to the best of your abilities. So just talk amongst each other for a few minutes. Anyone want to talk amongst each other? So if you're not close to someone, get up and go and talk to someone. The key here is to talk. So that's a question we're going to ask. Does it matter if there's an age? It does. Yep. All right, guys, we might stop there. So, who wants to throw an appropriate disposition? What are you going to do with this patient?
I would suggest transport, but be more than happy with a decision to see like an arthritis GP or something.
Okay, based on.
Based on the fact that they're at home, they seem relatively okay. They're
Yep.
the only thing that concerns me is that they're home alone.
Okay.
But if they obviously it's gastro of some sort, so like going to hospital might not be a good decision for them.
Mhm.
And then we'll be more comfortable seeing them on that.
Okay. Cool. So transport with referral, non-transport with referral.
Non-transport with referral.
Okay.
Like inject with the medication, you do have to be careful with your P5.
So we'll come back to that.
Yeah.
Yep. What about everyone else? What are you thinking? Who's got another transport disposition?
I'd transport them on the basis that they've been vomiting, diarrhea for 20 hours, not able to eat, and only able to tomorrow to walk out.
Okay. Yep. And why?
Because if you leave them, they don't eat or drink, go back to where they were, I guess.
Get worse. Yep.
Also, they're home alone.
I'm also worried about his BP because, so we've done it supine.
Beautiful.
So
What's
what
that
about
got
if
to?
he stands up
Yep.
and has a faint because it drops.
Beautiful.
So you want to
So can you go get yourself? Yeah.
BP and
Yep.
see how it goes.
I can guarantee it'll probably drop about 15 or more
So I think
milligrams
that's a
of
bit,
mercury.
Yeah, that's low. That's
If
a
you're
bit
supine,
concerning.
that's when your blood pressure's at its highest. Yep.
And also he's dehydrated. His BGL's a little bit too low, and that's probably because he's not able to eat,
Mhm.
drink, etc. So I think he would need fluids.
Mhm.
In that case, you can't really give fluids without transport.
Can you?
I don't think so.
We'll come back to that. That's a very good point about the blood pressure. Was anyone else concerned about the blood pressure? Yep. It's not outside the flags, is it?
Borderline, like,
Borderline. Yeah.
I'm not happy with it.
Yep. What's causing? So we're saying the patient's a little bit tachycardic and they're borderline hypotensive as well. So what's happening? You mentioned dehydration. What do you know about dehydration? Who can tell me what the body does with dehydration? So what one of the first signs that you will see in a patient that's dehydrated? What's one of the first signs you see? Pardon? Yeah, you may, but there's another subtle sign. Well, it's not so subtle. It's an observation that you take that kicks in first. Isn't that your cardiac anatomy, sympathetic activation? Who said that? Tachy? Yeah, you get tachy. And then you keep going and you're going and you get more dehydrated. You get tachy, but what doesn't change if you're in mild dehydration? Your blood pressure doesn't change. So my concern here would be that you've gotten up to a point that now your body's saying, I'm not compensating that well and I've just dropped my blood pressure. So I've gone from being mildly, who thought this patient was mildly dehydrated? It's okay to be honest. When I first read that for a second, I was like, oh yeah, just a bit dehydrated. And then I was like, oh, hang on, not so much. So it's okay if you thought that, yeah? But we'll dig a little bit deeper, change our thinking and our outset a little bit. He's not compensating well enough. So does that change your mindset about if you're going to transport this patient or not? If you think he's gotten to moderate to severe dehydration because his blood pressure, how could you tell if that was this person's normal blood pressure? Beautiful. Ask. So if this person's normal blood pressure was 110, how does that make you feel? Better. What if this patient's blood pressure was 180 normally?
That would be highly concerning.
Beautiful. It would be. Is everyone on the same page as that? So to check and see if you think something's low, always ask someone if they know generally what their blood pressure is. Yeah. What else is concerning in the patient presentation?
Actually know anything about with the pelvic pain.
Mm-hmm.
Is that just from cramping from going to the toilet, or what would that be about?
It just depends. You're probably going to have a look at the abdomen, make sure there's no external bruising. You're looking for the pulsating masses and things like that.
Yeah.
Getting a description of the pain. So does it come and go? Does it fluctuate with when the diarrhea occurs or when the vomiting occurs? Because generally there's some kind of cramping before it all happens and kicks off, and then there's a release and you feel better, and then it goes back into that little cyclic pain. So it's quite cyclic in that manner. Yeah. Be concerned about that. What else? Is there any other obs there that are a little bit... Okay, why is that a concerning factor? Well, what does that mean to you if the BGL is a little bit low? Beautiful. And can a normal person compensate pretty well? Yeah. So if you had someone GCS 15, responding well, alert and cognitively well, with a BGL of 3.4, is that concerning? Is anyone concerned by that? No? Would you actively treat a BGL that was 3.4 if they didn't show any signs of cognitive impairment? I probably wouldn't. I'd probably note it, but, you know, it's not... if I was very concerned, I might want to reassess it a bit later and make sure that it wasn't dropping. Yeah, because you can't get a set of trends or a clear picture of what someone's vital signs are doing with just one set of obs, so you need to do more than one. We talked about everyone needs to have 2 sets, but then you'd argue that's one to another. You're not really comparing too much. If you get a third one, then you've got a really good comparison. Yep. What else in there? SpO2? 96? If it's normal for them? It might be. What wouldn't make SpO2 normal? What could make that result? Like, it's not too low. They're not in respiratory distress, but what could make that sit at 96%? Pardon? Yeah, to get that prolonged, yeah. Probably not overly, they'd probably pass out before their sats changed too much if they were hyperventilating. Nail polish, some kind of respiratory condition, concern, early stages of COPD, for example. So if you're concerned about that, exploring more about why, that's 96. Do they have nail polish on? Easy, simple, good to go. You know, but they are a little bit poorly perfused as well. So, but we're not overly concerned at 96. If that patient was sitting at 93 and they had no respiratory problems, that'd be a bit different. But if they're 93 and had COPD in the same situation, again, your levels of what's acceptable and what's not in this scenario change depending on what the patient presents with. So we can't give you clear guidelines on every single condition like I was saying earlier, but we can give you that mindset that you need to explore everything that's there, because if you don't explore what's there, you'll miss something. Yeah? Anything else? Cool. What does that mean? What's bile look like? Cool. Where does that come from? Kind of liverish. Yep. So you're at your end of your tether. You've vomited up everything in your gastric contents, and now you're vomiting up some bile, some juices. Yep. So you know if they're vomiting actively in front of you and not able to stop, that's probably a bit concerning. Yep. Are you going to ask to look at it? Yeah, cool. Anyone not going to look at vomit or diarrhea or stool colour? Anyone thinks that they shouldn't be looking at that? Honestly. Because a lot of paramedics go out there and they're like, I'm not looking at that. You know, why do I need to look at that? You need to look at it because what if there's something concerning in there? What if you leave this gastro patient at home and yes, you've seen their vomit, you haven't even looked at their diarrhea, and their diarrhea is full of frank, copious amounts of red blood, and you've just missed some internal bleeding that's going on. And the reason the patient's tachycardic and verging on being hypovolemic even is because they're having a GI bleed. You know, so that's something to consider as well. You do need to look at things, and we'll get through that in a little bit about some exclusion pathways for gastroenteritis in particular. And if you haven't seen their stools or their vomit, then you cannot put them under the P5 pathway, which is quite interesting because most paramedics won't look. I don't see anything wrong with it, to be honest. It's the bodily function. You get so used to that anyway, so why not just have a look? Is anyone concerned about the temperature? Talk to me about the temperature. Pardon?
It's like low grade fever.
Yep. Low grade fever? Cool. So you might ask if you tried to take anything at some point? What if they had, with those sips of water, taken some Panadol? So if I'm ever worried about temperature, I always ask, have you taken anything for this, or have you taken anything for your pain? Because if they have and they've got a temperature of 37.5, what's that masking? So if you're leading down towards a non-transport and you give it 37.5, could you not say that there might be something brewing and you've just given some Panadol and left the patient at home, but they're tachycardic and verging on hypotension as well, so they may or may not be going down a sepsis pathway. So that comes back into play. I guess you're thinking about, what was I going to say? I've just lost it anyway. What you're going to do once the patient isn't in your care. So if you left this patient at home and they deteriorated more, how is the patient going to tell you what their blood pressure is going to be? So if you say, just monitor your blood pressure. If you feel any different, call us back. You know, if they start getting febrile, if you feel any different, call us back. If you feel like you've got a fever, call us back. If they've never had a fever, they're not going to call you back. They don't know what that is. They assume fever is hot, but if they start to get to that stage that they start having rigors, then they feel freezing cold. you know, so making sure you educate your patient as well. So what are some risks if you were to leave this patient at home? We've mentioned a few, but what do you think some of the risks are? I like Jackie's one when you said if the patient has a collapse. So if you haven't done a postural and you leave the patient at home and say, you'll be right, you're having some sips of water, I might have given you a bit of fluid, I might have given you maybe ondansetron and you're feeling better, so I've left you at home. But can that patient that's home alone get to the kitchen to get something to eat or get something to drink without collapsing? If you haven't tested if your patient can do that, then you really shouldn't be leaving them at home. But if your patient gets up and stands around and is responding to some of your treatment, that's a different story as well. But these cases don't just take 20 minutes. These cases will take an hour, 2 hours, 3 hours. But that's better than that patient that's got that's, you know, cognitively impaired at a nursing home, that's got query gastroenteritis that you take to hospital, that gets delirium, that gives all other patients, say chemo immunocompromised patients, gastro. Some of them die and whatnot, and then they get a delirium, they've got gastro, no one wants to touch them, so they sit in a corner and wait for a few hours to get treatment, as opposed to you treating them for 2 hours to seeing if you can mitigate some of these risks for that patient. So you've got to think, yes, it might be some of my time, but what's best for this patient in the scenario? So does anything change if I tell you the patient's 26-year-old male? Yeah? Why? Why does that change your mind? So if I said this is an 86-year-old man or a 26-year-old man, why does that change your mind? Yep. Yep. Yeah. Yeah, they don't come back. Their decompensatory mechanisms decrease the older you get, unfortunately. Liam?
The older they are, you usually sort of think sepsis more early.
Yep. Yep, so there's some early identification signs there that you think, well, as Ginny was saying, they're not going to bounce back from that. It's not something they can bounce back from. Maybe the 26-year-old can't either, but I'm probably going to try a bit harder with that 26-year-old. Because I know that people over the age of 65 generally have an increased falls risk, even, if you will. So, you know, even if the 86-year-old gentleman lives at home by himself and does recover after I've been there for an hour or two, I've got to start thinking, what's he going to do over night time if this kicks back off again? Gastro usually has like a 13-hour shelf life, if you will. And you know that if there's vomiting and diarrhea, it's happy days. That's gastro. If you've just got vomiting or if you've just got diarrhea, it's not gastroenteritis, no matter what anyone tries to tell you. And they are significant red flags. You should not leave anyone at home that just has, for example, vomiting in particular. Yeah, because they do not have gastro. Something else bad is going on. Yeah. Yeah. Like, would it change again if this person was at a dance party? Do you reckon? It'd be different if they said, yeah, you know, or the 32-year-old mother that's kids, you know, the whole daycare has had gastro. You know, does that change? So I guess I'm just trying to get you guys thinking about how your mind thinks and what is acceptable and what's not to you for clinical decision making. Yeah? So with this patient, to mitigate some of those risks, if that patient turns around and says, I don't want to go to hospital, and they are competent and have the capacity to make that decision, and you've explained all the risks to them, and they turn around and say, I don't want to go to hospital, doesn't mean you don't treat them. You can make your recommendation and they can refuse. if they show that competency capacity. But you can give them fluids. There's nothing wrong with giving fluids and giving IV on Danzatron and then taking the cannula back out if you're going to leave them at home and if you're happy with that. If you're not sure, you can ask your partner. If you're not sure, then you can ask the clinical advice line that every ambulance service in Australia has, that you can call up and say, this is what I'm presented with. I've done my abdo assessment, it's soft, there's no signs of rigidity or rebound tenderness, there's no hematemesis or melena. I'm not concerned about anything else at the moment. I've done an ECG. I really want to give this patient some fluids. Is that okay? And they will tell you and they will give you advice, and that's okay because you've got the best interest of the patient at heart. You might call the patient's doctor and the doctor refuses to see the patient. So then what are your other options for that patient? If this patient's picked up and they're going really well and you think, oh, I really want the doctor to see this patient, but the doctor says no, he needs to go to hospital, which happens because some doctors just don't care. And it's easier for them to say, well, the ambulance is there, you just take them to hospital because they're a bit ignorant in their ways. So, what are you going to do then? What are your options? Do you have to take them to hospital or can you source out another option? Can you call an after-hours service? And there are after-hours services in Sydney and other areas that do provide that, even if it's not your local GP. So there are just a lot of different options to think about. So when we're determining patient disposition, we've got to think about that we've done that complete comprehensive examination, and part of that examination is determining if they have competency capacity. We're assessing that clinical examination, the risks that are associated with leaving that patient at home. No matter what we do to them, if we're going to leave them at home, most patients I try to find an alternate to hospital for, but they have to prove to me that they fit that criteria. Not, please, 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 I fit, but can I exclude all these red flags? All these assessments that I'm doing, the worst case scenarios, if you don't fit those, then you've proven to me that, not that they have to, tell me I've proven to you, but, in my mind, that they're safe to go on an alternate pathway. Yeah? Not just leaving them at home because it's easiest to do and leaving them to fend for themselves. Because you'll probably lose your registration if you do that. Risk assessment, risk mitigation strategies, mutual shared decision making. We talked a lot about including that patient in that decision making, or including the family members and getting everyone on board. The healthcare workers, if you're going to say, I think they've taken it out now, or they might take it out shortly, about patient to make contact with doctor. That used to be in our ECP paperwork. There's no point patient to make contact with doctor because you then do a follow-up, because ECPs, we follow up all our non-transports. But that's not done widely across the whole service. But, and you're like, well, what happened in that stage? I saw you physically get in the car to go to your doctors that where did you go? If you got in the car to drive there, where did you actually go? Because you stand in the driveway and they've driven off. Yeah, we're going. You're like, okay, cool. At what point between here and 5 minutes away did you decide not to go? It's just odd. So people do odd things. So don't expect them to do what you say. Yeah, so make sure you follow up with that if you can. So say, yeah, you're booked in for this time. How are we going to get you there? How are you going to get home? So confirming that all, and part of that is documenting it. Because if you have these conversations with doctors and make appointments and things like that, if you haven't documented, it didn't happen. So if you turn around and say, oh yeah, but no, I remember that case, and no, I told them to go to their doctors, and you're like, did you? And 2 years down the track at the coroner's court, you're like, yeah, I actually did. And you're like, how do you know? The patient never went to their doctor. It says nowhere in your paperwork that you've referred them to the doctor. Or which doctor did you refer to? Always get the doctor's name. Always get whoever you speak to's name. And I always write down their phone number because generally you're on the phone to them. Yeah, so write that down in your paperwork. It's something to include as well, because part of that mitigating risks is people think, I've got to cover my own butt, that's why I'll take them to hospital. And whilst we're trying to discourage that, you need to also be confident in your decision-making abilities and not transporting that patient, but that also means doing proper documentation to attest to that, which we talked a bit about last week. Informed and valid consent and complete documentation. So in that scenario, we talked a little bit about, but what could go wrong for the patient and what specific risks and how can we mitigate them. So every scenario that you go into, not scenario, but any patient that you go to, you should be thinking, what can go wrong for this patient? Even if I take them to hospital, what can go wrong for this patient? If I don't take them to hospital, what could go wrong? If the patient's really sick, you're probably already thinking, what can go wrong with this patient? But these are for the patients that you want to think long term, that you're not actively doing treatment on, because you don't care about a patient that's in cardiac arrest. You don't care about their disposition. Yeah? You're busy doing stuff. Same as your asthma and extremists. You know where this patient is going. There's no ifs or buts. The patient needs to go to hospital. So, you know, but it's for the different type of patient that you've done a good clinical assessment on, and then identifying, having those risks as part of your mentality for leaving a patient at home. What's the worst that can happen to this patient when I leave? Not when I walk out the door, but what can happen to them tonight? What can happen to them in the next hour, 2 hours, 3 days? We know elderly people, if they have one fall, they're more likely to have another fall. You know, elderly at risk screening. Tick. One fall in the last, I think it's 6 months or something. They've had a fall. They tick it. They're an elderly at risk if you leave them at home. You know, so thinking about all those kinds of things and how you would put things into play or who you would contact to help you with that is always really important to think about. So this was in your pre-readings, 2007 UK study, and it was about the attitudes of paramedics about deciding whether to go to hospital after they get the call. And they found that there was a lot of discrepancy. 2007, it's changed a little bit between what the organisation expected of paramedics and what paramedics thought of those pathway referrals. So there was a lot of discontent, and it's reflected here in Australia between will I be backed or won't I, and the main service of ambulance services is to transport people to hospital, and that's what we do. But you'd all be aware and totally disagree with that now, otherwise you wouldn't be here, because, you know, 8% of our jobs are trauma, if you're lucky, and part of that 8%. You know, some people don't get big trauma and they get low acuity all the time, and they can count on one hand how much big trauma they've had in 10 years. Other people get heaps. So you don't know where that 8% is dispersed. So most of our jobs are lower acuity jobs that we can be very impactful for. Okay, so just be mindful of that. There's another one by Paul and Rick and Jason. I don't know if anyone knows Stephen Loud or Bill Lord, but they're also lovely people. Very, very good research academics in paramedicine. And that was about popping Nana back into bed. We'll talk more about that. But when I first started, I thought it was so wrong. We go to people that have fallen, and then you just pick them out of bed, put them back to bed, say, oh, you're happy being in bed and you don't want anything else? They're like, no, okay, sign here for me. Thank you. And then you just go. And I'd be like, should we do a set of obs? Don't even get those obs out. Do not get those out. I'm like, but how do we know they're okay? What, you know, and then the patient would start telling them how they've fallen. And then the paramedic's like, oh, that's all right. You're up now. You'll be right. Don't worry. If you need us, call us back. Out the door. They were the quickest jobs, and I never felt right about it. But at the time, there was no extra knowledge from a lot of people about why people fall. There was no studies or documentation or research that was being filtered into all the staff in the ambulance service about falls risks. So when I tried to bring it up, it was, no, hush now, Proby. So, you know, if it doesn't feel right, don't go with it. See how much you can intervene, and if you can't, nowadays there's a lot of avenues you can explore in that regard. Whereas 10 years ago, it was a different scene. So, and what this basically found was paramedics caring for older fallers had a total, pretty much disregard for full patient assessment. We'll put them up, they'll be fine. But why is the patient falling out of bed? Why can't the patient get back into the bed? Why can't the patient get up? Yeah. Patient can't get up because there's no one else there. So what happens when you leave that patient and they have another fall? Oh, they're trying to get up to go to the toilet and they had a fall. So next time they try to get up to go to the toilet, they're going to have a fall. That's what's going to happen. Yeah. So Paul's done some amazing research within ambulance service. His PhD was on falls in the elderly. He's the fall guy, as he'll happily tell you. Since that publication, they've got a falls risks coordinator that deals with this, because we do go to it. Who's been to a patient that's fallen? Did they pick them up and put them? Did anyone get one where they just picked them up, reassured them, / coerced them that they were fine and just left them? A few. And was it a bit like, it's kind of a bit odd? Did the patient need to be assessed?
We're pretty happy.
Yeah.
That was my first job on place, so I was like, oh, it's a paramedic.
Cool. Yeah, let's go with it. Let's ride. Yeah. Yeah. Most other people, the patient got a set of obs. Did the patient get one set of obs and then sign some paperwork and walk out? Or did they get a thorough assessment? Hands up if they got thorough assessment. Oh, stop it. That's wonderful. Oh, because you were doing it. Love it. All right. So there's lots of hits and misses with that. And that cognitive bias when you walk into a job of a fall. Oh, and it'll just say in the notes, patient needs help up. So you've already walked into that job going, I'm going to pick that person up and I'm going to go. That's what's happening. I'm going to go and get my, I'm going to go get my coffee, or I'm going to go get my dinner or whatever. It's night shift. We're going to go get some kebabs or something. Who knows? So just being mindful of people's cognition about going to falls as well and not treating them properly. Like again, shop talk with my husband. He went to a 97 or 98-year-old that had had a fall. And literally, can you pick me up? Picked her up. And then they said, oh, can we do some obs on you and check you out? She said, no, you can go, thanks. Please turn the light off on your way out. It's 3 o'clock in the morning. She lived by herself. And they're like, no, we really need to assess you. And she goes, no, look, I know I can have another fall and I feel all right and I really don't want you to assess me, please. And throughout the time that they were picking her up, they felt her pulse and it felt okay. They were able to establish that she had competent capacity, and they'd met her before, so they knew what she was like normally as well. But she pretty much said really nicely, just F right off. Just get out of my house and turn the light off on the way out. And he was like, but we really need to do your assessment, and to that she said, I'm 97. If something's going to kill me, let it. I don't want to know. Okay. But that puts them in a difficult field legally if something was to come back from that, or she was found dead the next morning, or deceased, pardon me. That then comes back on them. Why haven't you done this? So, it's hard sometimes, but doing the best that you can and then documenting it like we were talking about last week is really important. Some of the attitudes were, I think it's also the fact that we deal with so much low acuity work that you just stop thinking and people get complacent and just don't want to think. The routine callers are the ones that you're going to lose your job over. Or your reputation over. You'd go to the jobs with a preconceived notion. This is old so-and-so and there's always falling out of bed. Let them go back to bed, they'll be fine. Or they'll sometimes just walk in with a blood pressure cuff. They've made a decision before they've even walked in the door. So these are like experienced paramedics that have good qualifications, that have good experience in the job, that are saying these things. So it's just to highlight that we all fall victim to it at some point in time. But what's the worst outcome for that patient? So always keeping that in mind. Yeah, because we're being paid to do a job as well and provide a service. We're just lucky that that happens to be helping people. So help them. Referral decisions. So basically that's the P5 protocol. Every ambulance service has something like this. Sometimes they're so rigid that you don't even get a look in. Yeah, but they're starting to get more and more relaxed about what kind of referrals we can offer. And these generic exclusions and protocol exclusions have come from data. So they'll be looking at a lot of people that bounce back, what they call bounce back, that get non-transported, that then have to recall an ambulance. And they might be, well, obviously chest pain and clinical suspicion of ACS. Acute abdominal pain. Generally anyone presenting with abdominal pain that's not gastroenteritis, except for uncomplicated gastroenteritis that you cannot confirm is uncomplicated gastroenteritis, goes to hospital. And that's from some training with some gastroenterologists and other general surgery doctors and things like that. And that is everyone's standard advice across the line. You don't know what's going on in that abdomen. Yeah, so don't assume that you do. History of syncope. There's a reason that person had a syncope. Yeah, whether it be some kind of postural dehydration related, or it could be a cardiac syncope, you don't know. It could have been a dysrhythmia that's occurred that's now not there anymore. Yeah, so a history of a syncope you need to take to hospital. They're excluded from this. But if they can then show competency capacity and they have the right not to go and you've explained all the risks to them, then you don't take them. But you don't make it a P5, you make it a non-transport patient refused. Yeah, don't just write patient refused to make it easy for you. You know, it's about what's best for the patient. So these all come back from people that have bounced back. So they're not just generally plucked, and they change according to what the latest data says about patients and the rebound effect that happens when we leave them at home. So each specific pathway has their own protocol exclusion. For example, suspected gastroenteritis, and this is Queen Ambulance Victoria, pretty much exactly the same. Paul, I think, wrote this one actually. Gastroenteritis, it tells you a bit what it is. Red flags, abdominal distension. Yeah, you shouldn't have abdominal distension if you've got gastroenteritis. Okay. Bile stain vomiting. Yes, I got you. Did you feel that? It was like on your, yeah, sorry. Of course you didn't feel it. That was silly. Fever above 39. Okay, that's something else going on entirely there. And a lot of abdominal conditions can be something that's inflamed, or you can think of pancreatitis, appendicitis, things like that, inflammation, infection. There's a lot that can be going on inside the abdomen that you don't know. Oh, again, that's a subtle sign, isn't it? Blood in the vomitus or stool. I guess that's for gastroenteritis completely, but if someone called you for blood in their stool and you're having an assessment and then they told you that they normally have hemorrhoids and their hemorrhoids feel like they're bleeding, that's a different story. Do they have internal? Do they have external? Is it more or is it less than normal? Because some people might just have simple hemorrhoids and that's annoying them and causing them a bit of pain. But it might be something further up the GI tract that's causing that. You just have to have that good history taking to be able to determine that. Okay. Vomiting in the absence of diarrhea and a headache. So if you've got gastroenteritis and any of these presentations, you can cross out the non-transport. Okay, the patient should be, your recommendation should be that that patient goes to hospital. None of us remember every single protocol and every single exclusion. So back here, for example, each of these pathways has specific exclusions to them. So you might go to someone with a head injury, and anyone that knocks their head or gets their head knocked has some form of head injury. Yeah, you just have to determine, is it a bad head injury and can I refer this, or is this a more serious head injury? So I could walk into walls, which, let's face it, I do, and I've got a head injury. It's probably sustained concussion like the footballers, but you know, that's something that you need to really investigate. You can leave a hypoglycemic at home, but there are certain red flags around that when you wouldn't, to do with temperature and a few different other things there. But I don't remember it. So how do I remember it? I've got my app on my phone, or I carry my pocket guidelines with me. You're not expected to remember it, but you're expected, if you're going to leave them at home, that you've looked at these. So I was in one of the sectors in the zone office the other Tuesday, and probably shouldn't have been included in a conversation, but someone just walked in and had a chat about something, and one of them were talking about some P5s that had come back, and they'd come back because they were written down as P5s, but they clearly met exclusion criteria for that P5 pathway. So what had happened was the paramedics got too lazy and they didn't go and check. So then it falls back as an incident and an IMS, it gets reported, and all these people have to be held accountable for that. You know, so it's easy as pulling it out, making sure they don't meet any exclusions, and following on with that. And if you have to turn around and say, oh, sorry, you actually meet our exclusion criteria, I'm actually recommending you go to hospital now. That's okay. Better that than leave them at home and they die or they get worse. Yeah, so don't let your pride stand in the way of making a good transport disposition or changing it if you need to, if something else comes to light. Okay, so yeah, pretty much P5 exclusions again. So red flags are a no-no, and P5 exclusions are also a no-no. Symptoms are greater than 12 hours, presence or suspicion of blood, clinically obvious dehydration. So that patient met clinically obvious dehydration. It wasn't just a bit of mild dehydration, it was a decompensating type. Inability to tolerate oral fluids. So, for example, when I'm on a normal car and I might not have my ECP kit with me, I might see if they've got access, or someone in the family can run down and get some kind of gastrolyte or hydrolyte or something like that, and then I'll bring it back, and I will have given them, potentially, if I could confirm that it was gastroenteritis and that they were going okay, I will have popped in a line. I will have maybe 85 kilos, 850 mils over half an hour. I'm not going to bolus it, and then I've given them an antiemetic, and then some Panadol, and then going to see half an hour later if they can tolerate some fluid, and then I've got some gastrolyte or hydrolyte ready to try and replace that as well. So they're just different ways that you can think about how someone's going to go and how they're going to recover well enough. And if you don't have access to it, there's nothing stopping you from doing these things. The only limitation to your referral and your capabilities generally is yourself, or general paramedics not thinking outside that square as to where this patient is best referred to. Okay? Everyone thought that was over. Just quickly, it will be shortly. This is the number again. We talked about the palliative care numbers down here. There's also after-hour GP referrals that I mentioned before. So general public number, paramedic use only for referrals. Yeah, Sydney Medical Services. So these people, paramedics make specific referrals too. You ask them, they get hardly any referrals. Their job is for paramedic referrals after hours. They hardly get any referrals, and they will go to that home or tell you when they're going, or if they can or if they can't. But no paramedics open their book, and you ask any paramedics if they know about this contact number, and most of them tell you they don't know what you're talking about. Yeah, or they'll be pleasantly surprised that it actually exists. So utilising what you have is really important. So I'll leave you with that one just to think about at home as well, and just to go over, and that's a CVA, left hemiparesis, and slurred speech. This patient's got terminal cancer, doesn't want to be treated, and you've assessed him. What are you going to do? What are you going to manage? How are you going to risk mitigate? Are you going to accept what they say? Some people would think that this patient, terminal cancer, clearly has got some kind of CVA, some kind of mental thing happening. Some people would schedule this, which is horrific. There's no way you would schedule this patient. You know, you might get someone else down there, the DOM, that's got more experience than you, or an ICP to come with you to convince this patient, to tell this patient what you would like to do. Because even though he has a right, I guess, to choose how he would like to die away from hospital, would he prefer to die with lots of problems in a more horrific way? Or would it be easier for him to go to hospital, get treatment for his presentation, and then come home and die? So giving that patient those options and understanding what those options are and how you're going to have that conversation with someone like this, who we'd all like to go to hospital for a number of different reasons, doesn't want to go to hospital. So it's a bit tricky, and where our laws and regulations fit into that. Have a look down here at WordPress, paramedics transporting patients against their will. Severe coercion is transporting a patient against their will. Just be mindful of that. So how much of what you're going to say is coercion and how much of it is just the truth and stating what is wrong with that patient. I'll be quick. Oh, too quick. So consent needs to be given freely, voluntarily. Competency and capacity must be present. New South Wales Ambulance say receive, believe, retain, explain. And if you ask them how they came up with it, it took them a week to think of things that rhymed to get that. But different services have different slogans. But can they receive the information? Do they believe what you're saying? No, can you explain it? And can they explain it back to you? Receive, believe, explain, and retain. And then afterwards still remember what you're talking about. Kind of thing. And if they can do that, then they're showing competency and capacity and can make their own decisions. Patient refusal of treatment. Most people have something in their documentation and processes that you have to abide by within their services, and every service is different. There's something on informed consent, again, which is in your readings as well, and what that means, and how minor treatment, major, urgent, and special treatment, so what all that involves. Referral decisions, again, you can have a look at as well. But we've talked about most. So administer of medication, as you said earlier, Jackie, doesn't mean you have to transport. Okay? Depending what it is, each service has their own guidelines. How much fentanyl, how much morphine, how much fluid, how much of so-and-so can you give a patient before it's okay to leave them at home? So that's within each jurisdiction. And it's up to you how that patient responds to that as if you leave them at home. If you leave them after 10 minutes of giving a medication, that's wrong. You're in breach of duty of care. You need to stay with that patient long enough to know that that patient is safe with that medication on board. You can't just give it and leave. Bless you. Okay? And there you go. There's also what you can give. Medication's high risk but suitable. So your morphine, fentanyl, atrovent, compound sodium lactate, your fluids, what you might be able to give. If you're giving any of these, not authorised for P5. Okay? But, for example, you could do an alteration and say, put in a clinical variation and say aspirin, because aspirin's amazing for tooth pain. So I've got someone that's got a really horrible tooth pain and I've referred them to their dentist. I'm probably going to give them aspirin over Panadol or Nurofen, but that's because I know my pharmacology and I know presentations, and that tooth pain responds really well to aspirin. So I put in a variation of clinical practice and not put it as a P5. So there are exceptions for that, but you've also got to document why you've chosen to ignore that and make that based on sound clinical decisions. Okay.